Well, thank you very much. Maybe we'll start with that last presentation, because clearly a number of questions have come up this afternoon and, about how does one accumulate the data to validate an innovation. How should those data be presented as part of what is a demanding pathway that will allow for adoption in all parts of our health delivery system, both independent and NHS. And you have answered many of those questions. I speak as a fellow surgeon in terms of very compelling evidence. But ultimately, how is the adoption going beyond your core local environment where you have worked and developed all of this?
So we have 31 sites throughout the country, private and NHS, and they continue to grow. But you have that scaling problem. Other people describe the scaling problem. The NHS is not designed to scale. That's the bottom line, unfortunately, for the innovators. There is no scaling mechanism nationally to do that. When we go back to the data part, the data is really important for us because actually we want to scale because we as frontline clinicians, whether you're a surgeon, anaesthetist, a radiologist, whoever you are, you need to have that data in front of you, not hidden somewhere where you can make a clinical difference. It makes a clinical difference to your practice with the patient in front of you. That's what we want to try to. But actually, the adoption continues. And actually, yeah, we have 15 different trusts who want to start and funding. How do you get funding to start these things? Despite you doing all these economic studies that people like NICE have told you to do, you're going to make an economic difference, but how do you make business case stack up?
So that is a very interesting question. I'll maybe work through the panel. Ultimately, I think what we're hearing is there's an awful lot of this innovation. It's very powerful. It can ultimately solve many of the problems, not all of them, but an important number of the problems that attend the delivery of healthcare today. But the adoption of this will require some investment. It will require investment in the core technology itself. It will require investment in people to develop them to be able to change the way that they work such that they can incorporate the innovation for maximum benefit. And that innovation will have to be provided whilst delivering in parallel with the reality of healthcare, treatment, management of patients today on very tight recurrent budgets. There's a question about the Moorfields model and what other disciplines and specialties it might be applied to. Before we look at that question, I'd just like to ask, you have across the Moorfields, let us say, broader system of 21 centres, have this now adopted as the way that you work. Is that correct?
Not quite. And this is where you get into the interesting kind of barriers to, I think, to adoption, because we in fact operate in 5 ICBs in those 21 locations. And so we've got it working in 1.5 ICBs. But at the minute, we have to painstakingly persuade each one of the other ones to adopt the same commissioning model. And that's the step we're trying to take with Dominic and the London region, is to kind of go over the top of that and say, actually, we should be thinking about this London-wide. Because without that, it's back to the problem he identified of for many things, the benefit will come when you can do both primary and secondary. I think it's less for you, but in this case, very much primary and secondary together. So that's what you need.
So would the rest of the panel agree that one of the important challenges we face, and the focus isn't only on the NHS, but the NHS is such an important centre of gravity in the way that we deliver healthcare in our country today, that being able to deal with the NHS and have the NHS adopt the kinds of technologies and innovations provides the greatest possible opportunity for their broadest adoption, for the provision of the commercial returns that are necessary from the investment that was sought in the first place to make many of these things happen and to scale them, but also provides the remarkable opportunity for our economy more broadly to demonstrate their true efficacy, impact on clinical outcomes and the efficiency with which we deliver healthcare in such a way that it is the best advertisement for export of this technology globally. How do we, yes, Cameron first, yeah.
I was thinking about Sandy's point and the beautiful way that Dominic earlier positioned, how would you construct an organisation to stop all innovation, which I thought was beautifully put. And it reminds me, and having not ever worked in the NHS and not being a clinician, so my hand's still up, I was trying to explain to someone about, senior NHS manager, about my view of the NHS being this most extraordinarily strong brand, under which sits 250 independent organisations. And he said to me, no, that's not you've got that completely wrong. The NHS is an extraordinarily strong brand under which sits 25,000 independent organisations, all of whom are very suspicious of each other. And when I think of Sandy and Dominic and the points they've made, it's like, how are you going to, I don't know. Honestly, sitting in the rack of my brains, how are you going to solve that scale answer? Presented that, I haven't got an answer.
Well, Laura, you're doing that at the moment. It does seem counterintuitive to have to battle, institution by institution.
I couldn't agree with you more. It's a complete waste of effort. Hence why I think possibly the optimism of this morning around, in a very constrained world, do we actually have to change how we operate, and therefore people are bolder and say, okay, I will, because in theory, London region can it's Dominic's point about we don't have the accountabilities and the money lined up. But if they can be just a little bit braver, I think they could create a proof point. I think you then ask the question, which is, okay, you've got a proof point of London. How do you scale from beyond there? But I still think it's quite intractable. I have to say, on a bad day, I slightly come back to the particular subspecialty, very, very tiny subspecialty in Moorfields, where we have two clinicians. One does all his work virtually, and one does all his work face-to-face. And they both insist that that is the correct and only way of dealing with it. So there is there's a human nature problem here as well, I think.
That is a typical, could be actually any surgical department in the country. But Sebastian, you have, of course, developed a unique relationship with a number of NHS trusts in King's Health Partners, but principally Guy's and St Thomas's for much of your initial work. How would you take what you've learned there, bearing in mind what we heard from Sandeep, which was slightly disappointing, that you have marvellous technology, and the first question the Chief Financial Officer asks you is, how many nurses can you get rid of? That is, a slightly worrying but understandable mindset because of the way that we look at money in the NHS. How would you take your successful model and find a way that we adopted everything that you're doing at the moment across all of King's Health Partners and then all of the southeast of England?
I might disappoint you, Ajay. I was surprised when I actually already was on the panel of the successful story. I think we are in the making, and in fact, the challenge we have with GSTT is the same challenge I think every other colleagues have, which is we have a lot of different layers to go through in a trust to get any technology being implemented. And you can have a very strong senior management team who's going to talk to you and say, yes, please implement. You go to a head of cancer center and say, yes, we want to work with you, and we're going to sign an agreement, and we're going to get access to data. It might take you 2 years to get access to the data if you're lucky. Right? So I think this is the challenge we have, is we have a lot of different considerations and people with different thought process about what their job is and their responsibility and their liability within the same NHS trust. We've been lucky enough that we managed to align those people, but it's been a lot of hard work and a lot of face-to-face conversation on some specific pathways, one of them being around digital health and especially in radiology. But how do you scale this up across trust? I genuinely do not know. And we still have the same challenge, which is that when I've got entrepreneurs coming to me and saying, I want to deploy into the NHS, my first thought is, how am I going to tell them this is not going to happen? And my second thought is, I'm going to I'm going to help you to go to FDA. I'm going to help you to get the US market, because fundamentally, the NHS brand is amazing. NICE is amazing, but it's not because NICE recommend your technology that you're going to get more sales in the UK. It's going to be all dependent of the budget of every single of those trusts and the procurement team and your ICB and so on and so forth, while you have 40% of your market in the US. So sometimes, I'm afraid, you need to go there to be able to be financially sustainable until you reach some penetration in the UK. It's perhaps not the answer you wanted, but it's actually much more close to the reality, I think.
Yeah, so I think reality is very, very important. And you mentioned a critical word in terms of procurement. There are lots of innovators here today who have been working very hard, have developed, as Sandeep, you have, as Alex, you have, innovations that have a strong evidence base, the evidence base that's defined by the NHS as a requirement to be considered appropriate for broader adoption. What have you learnt about the opportunity for the procurement system for the NHS to drive the adoption of your technology, your innovation, once it's jumped through all the hurdles or over all the hurdles?
I think the frank answer is the procurement is very, very difficult. And it is, instead of being century-led, which it should be done, particularly where we have specific problems. There are national problems. You've identified this, the waiting list problem. That is a national disgrace. And we should be doing everything we can, and there are solutions that can solve that. And it should be done centrally. But it's not, frankly. And actually, the money part should be taken off the table, and we should be working with trusts to say, actually, this works, get on and implement, and do. Or integrate into EMRs or integrate into everything you need to do. And then you can change things. So we had a big private hospital group who we're speaking to at the moment. And they want to centralise part of the surgical service they're doing. And at first thought, you think, that's a terrible idea. But actually, if you think about it, digital technology is essentially risk stratifying patients. So anybody who is low risk, you have very little risk. Why should you travel an hour to a hospital, sitting and waiting for an hour, see somebody for an hour, and then go home when you can have a 15-minute phone call? And if you accept you can have a 15-minute phone call and there is no risk to that, does it matter where that phone call is? And if for the organisation, so take London, for example, why is all of London not assessing all its patients in 1 or 2 or 3 centres? Because all patients are assessed the same way. Okay? And if we have a reduction in resources, we don't have nursing staff, and you let them work from home, you let them because they have technology, or you let them work from selected centres that are perhaps not warehouses somewhere, they're a nicer environment for them to work in, you can offload a lot of this work far more efficiently and leave the patients who actually need to be seen for whatever reason and need the time, they need the care. Those are the ones who go into the hospitals and have that done. So it's using technology to transform how you set services up in a similar way that you were describing in terms of ICE, but on a much broader scale. And this private hospital group, 400,000 patients, 32 different hospitals across the country. And they're talking about one centre to do all their low-risk patients. Why not?
I feel your pain on procurement, I really do. And again, I still have no answers. I mean, for us, it's much, much, much easier because we are a commercial data partner for all of our foundation trusts. So not only do we create investment every year into their data warehouse, we recruit staff for them, which we pay for, and then we generate them significant income over the short and medium term. So that procurement process with the finance office is fine. It's money in, no money out, and a huge amount of, not a huge amount, but investment and knowledge acquisition within the data warehouse as well. So that tends to be a much easier conversation because we're a revenue generator, not a cost. I guess the thing that takes longer is the acceptance of the boards, the privacy, the anonymity protocols that we have, and making sure that is appropriate and signed off and in line with each trust's slightly different processes.
What role should the private healthcare sector be playing as a driver, an adopter of innovation, and the testbed for that innovation for ultimate presentation to the NHS? A lot of the thinking is it's got to be tested in the NHS first and then flow out, but it could happen that way potentially.
Yeah.
Do you see opportunities for that?
Yeah, our first hospital that we ever went into was a private hospital, and we proved a lot of the technology out in a private hospital. And in fact, if you come back to that data part, private hospitals are doing these phenomenal numbers of cases each year. And actually, what they're not realising is the value of the data that they have on these patients, which comes back to the point you come across.
If I can perhaps pivot slightly the question, it could be as well that because you need very specialized people with the appropriate expertise sometimes to understand really how you're going to deploy and implement this innovation in your workforce. You could have, as much as you have some dedicated centers of excellence which could do your diagnostic, for instance, or your intervention, rather than having it across many sites. You could have dedicated center of excellence which going to be your test bed. So rather than having, which is happening at the moment, every single entrepreneur will go to their local hospitals or the hospitals that they've been recommended to work with, rather than to go to a very specific place when they will talk to the right people. So it's a bit of a random walk and a kind of a survival of the fittest. You will knock to doors in different NHS trusts until you find someone who is willing to talk to you, or if you know the right person to talk to. That's what an entrepreneurship journey looks like in the NHS environment. But if you had really specific places and you can go, and with your specific type of discipline and research innovation, which are ready to embrace this innovation and demonstrate on behalf of the rest of the community and the NHS that this is adding value, and you could use this not as a stamp, but as a way of delivering at scale, I think we will save huge amount of challenges right now that we are facing.
That's a very, very interesting concept. Just to come back to Sandeep and then back to you, Laura, the issue of the loneliness of being an innovator when trying to deal with the healthcare systems, private and NHS in our country, is an important one. Laura, let's start with you. How have you, in Moorfields, helped those innovators to feel less lonely and to feel properly engaged?
I think it's a hugely important question, because I come back to those two clinicians and the human nature point. And I think what we have tried to do is all the softer things that you would think in terms of recognition, more freedom, more ability to get stuff done, is probably what we have brought people as kind of part of the, in a way, the package, the reward. But I think it's not easy, I would say, because whether it's the pay structure or anything else, that's what you're going to come back to, some of that softer stuff and the ability to make a difference that will matter to people.
Sandeep, have you felt not lonely? Have you been supported along the way?
I think it is a very challenging space as an innovator. Let's be just open and honest and frank there. I think there are, your biggest source of comfort is fellow innovators who share your pain. They talk about procurement, they talk about all the things, a bit like everybody talks about off the record, Chatham House rules. Yeah, frankly. I think that's the most important things. But there are great times, awards. You see, we see NHS teams, so those awards are NHS teams, because we believe, give people technology, they're not daft, they know how to improve their jobs, they just want the right tools, they will do it. That makes you really happy. Then there's a downside, walking into a CFO gives you comments like that, or procurement, you're thinking, we're on the same side here. So, fellow innovators, and obviously there are support structures like various accelerators, etc., and the HIN program nationally. But it's a tough ride, make no mistake.
Yeah, please, Alex.
If I listen to some of the stories we've heard today, and to go back to your big question that you started with about the criticalness of waiting lists and society and good health and these challenges that are faced. The one thing that I hear today just slightly worries me a little bit at the margin is there is no doubt we're the foothills of the biggest intelligence age the human race has ever seen. And if my friend from AlphaFold and who did that great job is right, the use of generative AI, self-learning algorithms, and high-value data is just at the beginning of a very long and exciting journey that will transform industries in a way that we can't imagine, and transform healthcare and climate change and some other major challenges to society. But worrying some of the things I've heard about, different lack of adoption, it's structured in a way that doesn't make it innovative. I think if our health systems, in all their forms, don't adopt that journey and say, we need to be on that journey, on those rails, I think we'll fall behind globally at an alarming rate, because this is the future.
I completely agree, and it's a very probably an appropriate place to finish this part of our discussion. Thank you all to our panellists for their marvellous contributions. Most grateful to you all.
The Harley Street Health District, the home of healthcare since 1860.